welcome everyone, and thank you so much for joining us today. Every year, our 3Terra team prepares an annual hospital analysis, which highlights key trends in performance, funding, and of course, showcases your data quality work. Many of the organizations use this report as an opportunity to bring departments from across the hospital together to align on upcoming priorities and discuss, strategic planning over the next little bit. So for today's session, we're going to try something a little bit different. So I'd like to welcome Matt, who's going to be joining and sharing how our Ontario hospitals are using these annual reports to drive meaningful conversations with leadership.
Great. Thanks, Jamie. Hi, everyone. My name is Matt Goertz, VP of Client Strategy here at 3Terra. As Jamie said, we're trying something a little bit different today. Instead of doing kind of a lecture style with slides sort of presentation, we're going to do a bit of a fireside chat type of format for this. And really what we're going to talk about today is these annual executive analyses. The annual executive analysis is really kind of two things in one. It has two parts to it. It's a 15 to 20 page PDF that we email to you, and it's coming soon. I'll talk about that a little bit later. Every client hospital that we work with receives it, and it has two parts to it. One is data quality results, and the other is analysis and opportunities within your coded data now that fiscal 25-26 is closed. The first part is all about quantifying data quality efforts and the impact at your hospital. And then the second part, the analysis, is really about understanding where and what year-end data says about opportunities within your hospital. And what we found is that those two parts kind of help bring different audiences in the hospital together. So, as much as you get this analysis every single year, the question that we're going to explore today is, what do you do with it? What should you do with it when you receive it? So looking forward to this.
Absolutely. All right, Matt. So the starting question here. Every hospital is getting one of these analyses, but a lot of them are never making it to leadership. So why exactly does it matter, both for the hospital and for the HIM team?
Yeah. So what I would say to that is the data quality work that your data quality teams are doing are a very direct driver, both from a financial perspective and a strategic perspective. Hospital teams invest an enormous amount of time, energy, effort in, doing a lot of data quality work. And the leadership team rarely has an opportunity to see what is the return that we're getting on that time and that effort. And that return can be stated a number of different ways. Historically, we've talked about it in terms of, the hard numbers. So how many weighted cases did we find? How many funded volumes like QBPs did we find? This is also an opportunity to talk a little bit more about the more nuanced things that the team is experiencing and the changes in the organization. So, our coders' confidence up? Are we seeing increased consistency amongst coders? How are our turnaround times changing? Are we seeing better ALC documentation? There's a lot of things above and beyond just the hard numbers that are worthwhile communicating to leadership teams. I think what I've found over the last little while is most health records teams and data quality teams don't necessarily have a natural venue or a forum for this conversation. And this provides kind of a really timely moment in the year where, we can translate the impact of the work that's being done into, dollars and volumes, kind of the language that leadership teams, speak. So I guess I'd kind of summarize it by saying if leadership doesn't know the impact of the data quality work that you're doing, they can't, get behind it. They can't champion it. And for most hospitals, this is really the primary opportunity and the primary point in the year where the impact of the data quality work can be translated into dollars, volumes, and organizational outcomes for some audiences.
I think that's a great way to sum it up. So, can you walk us through what's actually in the analysis? Like, what typically happens when you sit down with a leadership team?
Work, weighted cases, QBPs, changes in process. It might be ALC documentation. What was the tangible result that we saw? The second thing is really more about what does the data tell us, I would say? Where are there opportunities that we're seeing in the data, and what should we focus on? And so specifically, we look at weighted cases. Every hospital wants to know, how are my weighted cases changing? It's not just weighted cases, though. It's activity. How are my volume and my patient days changing? How is my ALC changing, my tertiary weight? Um, what are the populations? So we do go a level further and say, what are the populations that are changing the most? Are you seeing a big increase in dementia? Are you seeing a big decrease in awaiting placement? And so on and so forth. And that's why it's kind of interesting, not just from a administrative perspective, but also from a clinical perspective. Um, we're basically 3 months into the fiscal year. Most hospitals don't have their funding letters yet. So something that we do, and funding letter for 26, 27, I mean, what we do at this time of year as well in the analysis is do a QBP funding projection for fiscal, the fiscal year ahead, not just for 26, 27, but for 27, 28. And that can be really helpful to provide your finance team with some semblance of what can we expect in the future. None of this is sight unseen. So we share this with the primary champions at the hospital ahead of time. We work through it together. We sit down and tailor it to your audience to make sure that it's consistent with the results that you've achieved and the themes that you've seen throughout the course of the year. And I mean, the last thing I would say about it is we found that the PDF itself is not alone. In fact, I think it's unfair to kind of drop it off in your inbox and say, hey, here you go. Here's a bunch of information at your hospital. Without, some spending time reviewing it and involving multiple stakeholders in the conversation, the value of it kind of gets diminished. It's not the PDF, the analysis itself, the piece of paper, that's the value. It's the conversation that comes from it, from a variety of stakeholders. And the other thing I would say is that some people, get a little bit nervous about this. This is not about auditing your team or the work that you did, or, how great results you had, or maybe when it was different from the year before. It's really about giving your leadership team evidence of the value that you're creating on an ongoing basis.
Yeah, absolutely. You've been in a lot of these meetings. So I'm curious, and I'm sure the audience is as well. What do executives actually want to know? Are there any specific questions that catch people off guard in these meetings?
Well, the reality is there's a broad range of questions that audiences commonly ask. And in fairness, we have been in a lot of these meetings. There aren't a lot of things that catch us off guard now. But I mean, if I were to kind of think about it, it would be audience by audience member specific that are kind of the general questions that we see. So if I were to start by maybe talking about a clinical leadership type audience, so maybe it's the chief nursing executive, maybe it's the chief of staff, a clinical VP, clinical director, this type of persona. Typically, their line of questioning when they see this analysis and when we present it to them is about the clinical indicators that are already top of mind for them. So recently, as everyone knows, conservable days has been a hot a discussion area from a number of different perspectives. A lot of the conversations that we'll have will be around conservable days and avoidable days, and ALC becomes a part of that as well. They want to understand a little bit more about what's driving, the problems that they have already, and what types of opportunities are there. The nice thing about that is that when you have that sort of question, it ultimately will lead to a conversation about how is clinical documentation impacting what we're seeing in the data. And this is very, very healthy conversation to have. And I'll give an example. A couple of weeks ago, I did a presentation to a leadership team, and the theme there was that their general symptom sign HIG group patient population had increased a great deal. And their question became like, why is that? And what does that mean? And is our documentation impacting that? And I credit the person that stood up and said, what does this mean from a documentation perspective? Because it wasn't health records or decision support that initiated the conversation. It was from the clinical side of the house. And it
Yeah,
created a really engaging conversation, which was essentially, Why is it being captured this way? Why is it being coded this way? What does that mean from a clinical perspective, an expected length of stay perspective, and from our documentation going forward?
It sounds like having clinical leadership in the room could open up so many different avenues for a conversation. And like you said, it's all healthy, right?
Well,
Having all of those voices in the same room is a great thing.
Well, and I particularly enjoy it because it's my opportunity to kind of take a step back doing these presentations because there's this natural conversation that evolves with health records in the room and the clinical leadership in the room, where clinical leadership is saying, why is it being captured this way? And health records is doing a little bit of education, which is nice to say, well, it's because it's being documented this way, or it's because we didn't receive a certain piece of documentation. And so it opens up that, important conversation between, health records teams and physicians.
Absolutely. So what about the CFO? What do they usually want to know?
Yeah, the CFO is really about, understanding how obviously funding is changing. So I talked a little bit before about the QBP funding projection that we do. They're interested in how that's working. There's always questions about, the CMI freeze for QBPs as an example. When is that going to be lifted? What will they do? What will the ministry do when that's lifted? When are provincial base rates going to be reinstated, and what is that going to look like? Those are questions that are really lingering for CFOs. I talked about conservable days before from a clinical perspective. This is just as important from a financial perspective. Um, Nearly every hospital that we work with is working through the HSSPs. These are the stabilization plans, financial stabilization plans, and conservable days is a key component of that. So that's certainly a big part of the conversation. Um, just like we said for clinical, like there's an education opportunity for finance, there is as well. I get a lot of questions about like how does CMI work? Do long stay cases get included? Does length of stay impact CMI? It's a great opportunity to do some light education to say, hey, yeah, you know what? 90% of your discharges are typical. Length of stay doesn't matter. Here's how they're funded. Here's how it works for your CMI. But let's then talk about, these atypical cases, the transfers in, the transfers out, the long stay cases. And it's always the case that this audience isn't well attuned to the inside baseball of how funding works. That's okay. It's a good opportunity to kind of bring it at a 30,000 foot level and kind of create some common conversation there. And then I think the last thing that we get from a finance perspective is there's always some variation of, is this normal? Like our weighted cases have increased by a certain amount. Is that normal? Our ALC has gone down by a certain amount. Is that normal? Um, that's something that we can't answer in the report directly, but because we work with so many hospitals, we work with 47 hospitals across the province, we can, provide color commentary to say, hey, yeah, you know what, the fact that your ALC is up so much and everyone else's is down by a certain amount. That's something that you might want to, take a look at a little bit more closely.
Yeah. Okay. So before I move on to my next question, let's round this out. What about the CEO?
Yeah. From a CEO perspective, usually it's kind of a higher level perspective on things. Very much the questions around how is this different than other hospitals, for any given metric that we're looking at. A lot of the time, it's more about, okay, well, you've shown me this thing. What should I do next? What should we look at next? And it's not to say that we'll necessarily have an answer in the room and on the spot, but we can say, well, here's the area that you should focus on. And it's not going to be 10 things, it'll be one or two things. And this is the next step in going down that path. Um, and then, I mean, inevitably, the question of artificial intelligence will come up along the way. All that anyone's talking about these days is AI and how it's going to impact every profession and every area of a hospital. We were out at eHealth in Halifax last week, and it dominated the conversation across any different conversation that we were having. That will inevitably come up. And there are some misnomers about what AI will be able to accomplish or can accomplish right now. It's an opportunity to say, like, here's where it fits from a realistic perspective at the moment. But that comes up a great deal from a CEO type audience.
Yeah, that makes sense. And I mean, we've been in so many conversations where it is coming up more and more, right? So it's definitely one of those hot topics. All right. So beyond the analysis itself, what's something that a hospital has gotten out of these meetings that they genuinely couldn't have gotten any other way?
Yeah, you know what I think it is? It's really the conversation around it and how things are different at your hospital. So I'll give an example. Last year, we had a hospital where we saw a big increase in COVID volumes and COVID weighted cases, and as a result, tertiary weighted cases and all those sorts of things. Um, they were an outlier. We worked with a lot of hospitals. Everyone's COVID volumes were going down, and they have the past couple of years. There was something different going on. This was an opportunity to really kind of talk about why that was different at their hospital, and the context that we don't have when we're compiling this analysis is what's going on, what are the changes in your hospital, how are things being restructured, what type of initiatives are going on. It was able to kind of open up a conversation about a trend that was different than everyone else, that we could kind of form into perspective here. I will say there's a fair amount of unpredictability to these meetings because we don't have all the context. So, you know, we noticed that there was a hospital not too long ago that had a big increase in hips and knees, and it came out in the data. We weren't able to necessarily tell them why that was, but within the clinical folks were immediately able to say, well, you know what, we've got an additional initiative that's going on, and that context helps to explain what's going on, and it's something that isn't worth necessarily tracking down. So every time we present an analysis like this, it's a little bit different. It's honestly makes it exciting and interesting for us as well because we don't know exactly how we're going to be able to help and where the conversation will lead, but it always opens up a conversation that goes well beyond the report itself.
Yeah, it's a great point. So, for someone who's joining us here and wants to pursue a leadership meeting, how does it actually work? What are their options?
Yeah. So, like I said earlier, we are going to compile this analysis for you as part of our year-end process. We've sent them to some hospitals already. If you haven't received yours yet, you'll receive it in your inbox in the next 4, 5, 6 weeks sort of time frame. You've got some options at that point in time. You can take the analysis and you can distribute it within your organization, and we welcome you doing so. But you can take it and present it yourself, and we'll support you in doing that. If you'd like our support to co-present, we're certainly open to that. We can break up the things that you're comfortable speaking with to your leaders, and the things that maybe we're well suited to present, and we can go about it that way. Um, we can lead the presentation, and you provide color commentary. This works pretty well broadly because you have some of the context that we don't have, and can certainly help to guide the conversation. Or, the last option is we can, fully run it on your behalf. We want you to be in the room. You provide a valuable voice to be in that room to answer some of the questions that are kind of come up in the conversation that will ensue. But certainly it's something that we can run if you don't want to be under the spotlight and then under the scrutiny of the leadership team. Um, Ultimately, when we give these types of options, most people kind of say, "Hey, you know what? Why don't you guys just go ahead and do it? You're used to doing these sorts of presentations. I'll be there to support you." But that's generally kind of where it goes. But you have all sorts of options, and in fairness, you don't have to decide right now. It's something that when you get your analysis, reach out to us. We'll set up a conversation, and you can decide how you want to proceed, who you'd like to include, and what kind of the key talking points would be for that sort of situation.
Amazing. All right, I think we're getting close to Q&A here. So, let me see what we've got in our chat. Ooh, I got one on the side. So maybe we'll start there because no one will have seen that one yet. So I'm a health records manager and I really want to get a leadership presentation, but I don't know how to go about doing it. What should I do?
Yeah, I mean, there's a couple of different options that you have. I mean, in a situation like this, you might not have a direct path to leadership. I would, first say, escalate to your VP, find out what the right venue is, and I'll say like these conversations are all kinds of different, take different forms. Sometimes we'll just be an agenda item on a meeting. Hey, Matt, can you come in for 15 minutes at the beginning of an SLT meeting, present this within this context, and then leave so that we can move on with the rest of our agenda? Absolutely. Um, if if we can get a full half hour, if we can get a whole hour, that's great, but it doesn't have to be that. I would say in this sort of situation, like escalate to your VP if you'd like us to help to coordinate things, work with the executive assistants to kind of get the right audience in the room. We can certainly help to facilitate that, but let's have a conversation about if that's your situation. Yeah.
Yeah, absolutely. What if I was nervous about what my leadership team is going to say about my results? Do you have any tips with that?
This is kind of an interesting. Um, I would say this is all the more reason to schedule a conversation with your team. And I say that because the numbers alone don't really provide the full context in terms of the data quality work that you're doing. And so like obviously we look at how data quality results are achieved year over year. How many QBPs did you find this year, but also how many have you found the past 5 or 10 years? Um, there's a lot of context to interpreting things. Sometimes you've got coding team turnover. You've got, sick leaves. Maybe you have retirements that are that are kind of creating capacity problems. Maybe your process has changed. Instead of reviewing things every week, you're reviewing things every month or every quarter. Um, Almost every hospital that we've worked with has changed EMRs in the last, number of years. You've got changes in physician staffing. All these things are more nuanced than just providing a number and forwarding, numbers and a return on investment to a leadership team. It's better phrased as a nuanced conversation. I think that would be kind of my response to that sort of a concern. Yeah.
Yeah. I mean, there are a lot of different ways, like you're saying, that the results can be shared in these meetings.
Well, and
Uh,
the other thing I would say is that like you have the context of what the team has also been focused on. We've got hospitals that are doing concerted work, obviously, on ALC. They're doing concerted work on HSMR. They're doing concerted work on hospital harm. It's important that that is part of the results that are communicated. And in my experience, being in the room, that creates a lot of intangible sort of conversation, which is I'm glad you're working on this HSMR thing. Our numbers didn't reflect how complex our patients were. We've coordinated with physicians on this, and it's an initiative that we're seeing some progress in. So it's a great opportunity to do that.
Absolutely. So there's a question in the chat here, and I apologize I missed that. Is AI currently being applied in practice for coding data quality and data analysis in your company or any other hospital?
Oh, wow. Okay. So, I mean, this is a big question.
It's a big one.
Probably a full webinar that we could do at a later
I
date.
know.
The answer is absolutely, to varying degrees in the different areas that you're talking about. So I think you talked about coding, data quality, and data analysis. Um, yes, to varying degrees in coding. Yes, to varying degrees in data quality. I mean, and maybe I'll speak more to this. We don't really apply AI to coding practice. That's not necessarily what we do. We do apply data quality AI. A lot of the rules that are in the platform, a lot of the work that we do proactively within the EMR integration work is largely driven by artificial intelligence. And then data analysis, absolutely. The AI is a big part of being able to find trends, correlations, analyses, things like that. But honestly, I couldn't even scratch the surface on answering this question competently in this amount of time.
Completely fair. It's a big one. It's a
I
good
would say
discussion, though.
um, we should look at adding this in as a future webinar topic. For whoever
Completely
asked
agree.
that question, if it's something that you'd like to drill down on a little bit more, reach out to me. I'd love to have a conversation about that.
Yeah, absolutely. All right. I'm not seeing any other questions in the chat right. Oh, there's one that just came in. What best practices have high-performing organizations adopted to improve data quality? What lessons learned could organizations apply before the next reporting cycle? It's That's an excellent question.
Yeah, this is another pretty big one. What are the big lessons learned? Excellent question. I would say a couple of things. The first is that the best performing organizations use the data quality tool on a more ongoing basis. And that might mean a couple of things. I would say certainly at the very least as part of a ongoing monthly process where the team is using it before doing submission to Kai and after they've done coding for that given month. I would kind of number two say distributing the data quality work and access to the information across the coding team is a big theme that we see. And the reason is not necessarily because the work is distributed. The reason is because now the learnings, the lessons learned can be can be distributed across all of the coders. And I'll tell you what often happens is our platform, Data Quality Assist, will say, hey, you should look at this case for this reason. Maybe the most responsible diagnosis requires review. And the coder of the case might turn to a colleague and say, hey, 3tera suggested this. I coded it this way with this sort of, rationale or reasoning. How would you have coded this? And what ultimately happens is a conversation that creates coding consistency, reduces data quality things that come up in the future, makes things a little bit more proactive. And I think that's kind of a big value from that. And then I guess the third thing I would say is moving data quality closer to the time of coding. So you don't necessarily have to wait to the end of the month to do the work. And I'll give an example. If you're coding a case that's a 30-day, 45, 60-day length of stay, there's a lot of documentation a coder is going through. In the ideal scenario, you don't want to revisit that in a week, in a month, on May 30th. You'd rather look at it more timely and while your head is within the bounds of the case and the documentation that's in there. A lot of hospitals are adopting, the ability to live refresh, review the case, and pull it directly from, the abstracting system and integrate data from the EMR to do that. That's something we talked about, I think, in the last webinar, maybe two webinars ago. We're seeing a lot of, value there to avoid retrospective checks that you don't need.
No, these are excellent points. And I mean, and once again, great conversation to have if anyone wants to follow up. I'm not seeing any other questions in the chat here. But as always, we're happy to have these discussions with you. So like I said, don't hesitate to reach out if you have any questions, if there's something that's, coming to mind afterwards. And as Matt said, everyone's going to be receiving these annual analyses shortly if you haven't already. So when it lands in your inbox, just reply to the email, please. And we can help you figure out what the best way is to approach getting these leadership conversations going. Uh, If you can take a few moments, complete our survey. We're continuing to do the raffle for the $50 gift card. So congratulations to last month's winner. And finally, thank you all for joining us today. Hope you enjoyed this new format, and we look forward to seeing you soon.